1 minute.
Okay.
Hello and welcome to this session of e-learning on 28 March of 2019. This topic today is patent ductus arteriosus diagnosis and management. And I'm Dr. Prem Shekhar, interventional pediatric cardiologist, bringing this e-learning session to you from Chennai in India. So let's move on. So this is a 1 hour lecture. Some of it is didactic, and I would prefer if the participants get interactive, and we can have an interactive session with questions and answers in between, which would make it more interesting. So this is the first slide of the aortic arch, the truncus arteriosus with the 2 dorsal aorta. And my question is, which part of the arch the ductus arteriosus is derived from? I hope the video and the audio is quite well heard. Somebody said 6th arch, so that is correct. So it is the 6th arch from where the ductus arteriosus is derived from, and usually from which side of the 6th arch, the right or the left? The left. Okay. So commonly the right dorsal aorta regresses, and you have the pulmonary artery. The left pulmonary artery comes from the proximal segment of the 6th arch. The main pulmonary artery divides and forms the left pulmonary artery from the 6th arch, and the distal segment between the the left pulmonary artery and the left dorsal aorta is what continues as the ductus arteriosus. So this is a cartoon of a patent ductus arteriosus. As you can see, it is a vascular tubular communication between the aorta and the pulmonary artery confluence. The aortic origin of the ductus arteriosus is just distal to the left subclavian artery, and the region from the left subclavian artery to the origin of the patent ductus arteriosus, this region is called the aortic isthmus, and it commonly inserts into the main pulmonary artery confluence closer to the origin of the left pulmonary artery than the right. So that being a systemic to pulmonary shunt, the hemodynamics, we'll have a look at it as we go along. Now, the incidence of patent ductus arteriosus is about 1 in 2,500 to 1 in 5,000, and with a 2-to-1 female preponderance. There is a genetic predisposition, although it is considered to be of multifactorial origin. There is some genetic predisposition with predominantly an autosomal recessive mode with incomplete expression penetration. And if you have a sibling, if there is a child with patent ductus arteriosus, there is a 3% increased chance for another sibling in the family to have patent ductus arteriosus too. So when you are seeing a child with patent ductus arteriosus, eliciting the history is quite important. You would ask the mother what are the salient, what are the important history that you would want to elicit. What preterm? Yes, good. Whether the baby is preterm and rubella, correct. Any drug usage? Previous sibling, okay. Any drug which is implicated in higher incidence of patent ductus arteriosus? Valproate, okay. So valproate use has been implicated in a higher incidence of patent ductus arteriosus. So that's one of the points that you would ask in the history. So moving on, now I want to ask you, what is the mechanism by which the closure of the patent ductus arteriosus is affected? Oxygen sensitivity of the SMS. Okay, after birth, yeah. Contraction. Okay, so if we look at the mechanisms, there are two important mechanisms. You have a intimal proliferation, yeah. So all those is coming through. So we have two basic mechanisms, which is you have a functional closure of the patent ductus arteriosus, which happens normally within 24 to 48 hours after birth in a term baby, and you have a permanent closure which happens about 2 to 3 weeks later. Now, functional closure is affected by two major mechanisms. One is contraction, like one of you answered, smooth muscle contraction, and the other is loss of sensitivity to the prostaglandin E2, or a decrease in the levels of the prostaglandin E2. Now, if you have to look at how this comes about, you have to understand the histopathology of the patent ductus arteriosus, which is quite distinct from the histopathology of the adjoining aorta and the pulmonary artery histology. So, with in the ductal tissue, the intima is fairly thick, and the media is fairly thin with a single layered elastic lamina, which has variable amount of mucoid material in it, and also has a smooth muscle cells which are arranged in a pattern which is distinct for the patent ductus arteriosus. They are arranged in a helicoid spherical helicoid spiral arrangement, whereas in the adjoining aorta and pulmonary artery, the arrangement of the smooth muscles is circumferential. So this again would contribute to the constriction which happens in the ductus arteriosus. The mechanism behind that being that the media being very thin is prone for disruptions, with the smooth muscle cells protruding through the media into the intima, causing longitudinal ridges. Also, there is hypoplasia of the smooth muscle cells. So these longitudinal ridges protrude into the lumen of the ductus arteriosus. And when there is contraction of the smooth muscles affected by a increase in oxygen tension, these longitudinal ridges again contract, causing intraluminal obstruction and shortening of the PDA, and smooth muscle contraction then adds to the closure of the patent ductus arteriosus. One of the other mechanism is the decrease in the amount of prostaglandin E2, which is found in abundance antenatally, because the lungs do not metabolize PGE2 antenatally, as the blood is diverted from the lungs in the antenatal period, and postnatally the lung starts metabolizing the prostaglandin with a significant drop in those levels, and consequently the duct closes. The patency is not maintained and it helps closure. So this causes the functional closure of the patent ductus arteriosus within 24 to 48 hours. And in 2 to 3 weeks time, they have enfolding of the endothelium, along with subintimal disruption and proliferation, which result in fibrosis and luminal obstruction and a permanent seal. So, am I not audible?
Sir, audible, sir, no problem.
Sorry?
No, audible, sir, audible, no problem.
Okay, because somebody said no audio.
Yeah,
This is how a permanent seal is affected in 2 to 3 weeks time. So in this is why in cyanotic infants, when their oxygen tension is already low, the PDA, which usually perfuses the systemic or the pulmonary circulation, as the depending on the underlying cardiac condition, it does not close. And also is important why you should not raise the oxygen tension in a cyanotic baby whom you suspect to have a duct-dependent pulmonary or systemic circulation. Again, in preterm infants, the prostaglandin sensitivity is more dominant than the response to the oxygen, and therefore the enhanced response to prostaglandin synthetase inhibitors like indomethacin, ibuprofen, etc. Again, in rubella, where PDA is a common association, the actual amount of smooth muscles in the ductal tissue is very sparse, and that is why there is a higher incidence of persistent patency of the ductal arteriosus in rubella. And so if we look at some of the data, in a healthy preterm who's more than 30 weeks gestation, 90% of ductal closure is affected by day 4 and 98% by day 7. If the baby is less than 24 weeks gestation, then there is a significant drop in ductal closure. The chances for duct to remain patent is higher, with only 8% closing by day 4 and 13% by day 7. Less than 27 weeks gestation with PDA at the time of hospital discharge, you have 75% closing spontaneously by 1 year, 25% need some form of intervention to close it at that time. And that's the reference for that data. Less than 1,500 grams with PDA at hospital discharge, again 86% close spontaneously by 1 year. So in preterm babies, the closure takes longer. The permanent closure takes longer for obvious reasons. And if the baby is not too symptomatic, you can wait up to a year to see if permanent closure happens or not. Again, the closure can, there is a genetic basis for closure also. There have been some recent studies which have revealed the presence of progerin gene expression in the ductal intima and inner media, which affects closure by cell lysis and apoptosis. So these are the clinical groups with PDA, and the reason we have grouped them is because the symptomatology differs in each of these groups. Persistent PDA is considered one where the ductus continues to remain patent beyond the physiological period when you would expect it to undergo closure in the immediate neonatal period. And PDA in preterms and neonates, as we have seen, is more common and can take longer to close, and the hemodynamics and the implications are different in the preterms and neonates as compared to older infants and children. PDA with pulmonary artery hypertension, when unattended with a large shunt over a period of time, goes on to progress to pulmonary artery hypertension, which can be reversible or irreversible depending on the response of the pulmonary vasculature to the increased flow. PDA in other congenital heart disease you commonly can be associated with simple left to right shunts like VSDs, coarctations of aorta, ASDs, and other conditions. Sometimes in complex congenital heart disease where they tend to be the lifesaver in the form of duct-dependent pulmonary or systemic circulation. And then we would also be looking at PDA with complications. Now, this is predominantly looking at PDA which have associated complications like aneurysm of the ductus, which can be seen during the antenatal period and also in the neonatal period sometimes. Majority of these spontaneously close off with when the duct close and they thrombose. We'll have a little detailed look at that in coming slides. Now, when you are reading about PDA, it's important to know the morphological classification of PDA based on Krychenko. These are the types of PDA. You have a conical PDA, which is the most common, reason being that the ductal constriction starts at the pulmonary arterial end, and you have a conical type A patent ductus arteriosus. Type B is a window type where the constriction happens at the aortic end. Now, if you look at this type A, this portion is called the aortic ampulla, the wider section, the aortic end. And this is called the neck of the PDA at the pulmonary arterial end, where commonly the constriction occurs. But here the constriction has happened at the aortic end, with the result that you have like a inverted funnel-like picture. This is called a window type of PDA. And here you don't see any constriction, with the result that you have a tubular PDA. And here you have constrictions happening at multiple sites, giving a complex morphology to the patent ductus arteriosus. Here the PDA is elongated with constriction towards the pulmonary arterial end. So you have a longer length of the patent ductus arteriosus. Now, why is this morphology important? How does this have a bearing on the management? Why do we need to know the morphology of the ductus while managing? Device closure, yeah. So it has an implication when we are taking the baby for transcatheter interventions to close the PDA, not necessarily device. Depending on the morphology, you can that determines the choice of the occluder. It could be a coil, it could be a plug, it could be a duct occluder. So that is why it's important to know the morphology beforehand. And many a times you can see the morphology by echocardiography, and usually just before the procedure, when you do the angiogram, you can see the morphology and choose your duct occluder accordingly. Looking at the symptoms, congestive cardiac failure is one of the major symptoms of a moderate ductal shunt in a infant or neonate, and this is predominantly determined by the shunt across the ductus arteriosus. Now, what determines the shunt across the ductus arteriosus? What would determine the shunt across the ductus arteriosus? What determines the magnitude of the shunt? Pulmonary and systemic pressure. Yeah. So the resistance across the pulmonary and the systemic circuit, as well as the resistance in the ductus arteriosus. So the length, the morphology of the ductus, the site of narrowing, extent of narrowing, all that would determine the shunt, as well as the pulmonary vascular resistance and the systemic vascular resistance. So in infants, sometimes the when the duct continues to remain patent, the pulmonary vascular resistance does not fall adequately, and this acts like a protective measure against developing pulmonary fluid overload and decreased lung compliance. So the child continues to grow normally until later age when it can be closed. But in some, the pulmonary vascular resistance drops drastically after the neonatal period at 2 to 3 weeks of age. And if the duct is significant, then you have a large magnitude shunt with a big left to right shunt and its implications like pulmonary congestion and consequently decreased compliance of the pulmonary tissue, alveolar tissue, and with the result that the baby continues to have tachypnea and feeding difficulties and failure to thrive, and that would be an indication for going and closing the ductus arteriosus. In older children, when you have a large shunt, which side of the heart gets enlarged? The left. And the reason being that you have an increased pulmonary left to right shunt, and there is increased pulmonary venous return, which comes to the left atrium and left ventricle. So there's volume loading of the left atrium and left ventricle, which causes left heart dilatation. So the cardiomegaly you see in a large ductal shunt is due to dilatation of the left atrium and the left ventricle. And over a period of time, if unattended, this left ventricular dilatation can progress to subendocardial fibrosis because of a combination of diastolic runoff, tachycardia, and endocardial ischemia. And that would again then result in congestive cardiac failure in the older patients. and can be associated with atrial arrhythmias when there is dilatation of the left atrium. Hypertensive pulmonary vascular disease is a consequence of basically an overflow situation which has been allowed to go into a chronic state. And do you know what the mechanism which causes pulmonary vascular disease and Eisenmenger's syndrome? What is the mechanism that causes hypertensive pulmonary vascular disease in a large shunt which is chronic? So basically, the excessive flow causes microvascular injury, which can release growth hormones, which can release some factors which then can cause proliferation of the intima and hyperplasia of the media and cause luminal obstruction with an increase in pulmonary vascular resistance. So if allowed for a long period of time, then this would cause obliteration of the lumen and an increase in pulmonary vascular resistance and reversal of shunt, with the shunt going from pulmonary artery to aorta, and in which case you would deem it to be irreversible pulmonary hypertension and Eisenmengerization of the shunt. Endarteritis is again a very rare complication of patent ductus arteriosus. The incidence is said to be about 1% per year, and usually the infective endocarditis, the vegetation tends to be on the pulmonary arterial side towards the neck, and any mycotic emboli which flows from this goes into the pulmonary circulation rather than the systemic circulation. Like we said, aneurysm of the ductus arteriosus is as high as 8% in children with ductus arteriosus, more commonly seen antenatally and during the neonatal period. Majority of them resolve spontaneously with ductal closure, but very rarely they can grow big enough to cause compression of the left main bronchus, and can also compress on the left recurrent laryngeal nerve, causing hoarseness of voice. And if associated with these situations and persistence of the patent ductus, or thrombotic complications where the thrombi extend into the systemic circulation or into the pulmonary circulation, then warrants surgical repair. Signs. Can you tell me the signs of a large shunt? What are the signs of a large ductal shunt? Yeah, hyperdynamic precordium, good. High volume bounding pulses, yes. Tachycardia. Okay, so basically the effects of a large left to right shunt, continuous murmur. And if you look at the auscultatory finding, you can sometimes palpatory findings, you may be able to feel a systolic thrill if it's a restrictive ductus. But if it's a moderate shunt, you do not have major palpatory findings. You're not able to feel the thrill. Auscultatory findings was described by Gibson. The murmur was described as begins after the commencement of the first sound. It persists through the second sound and dies away gradually during the long pause. The murmur is rough and thrilling. It begins softly and increases in intensity so as to reach its acme just about or immediately after the incidence of second sound, and from that point gradually wanes until its termination. The second sound can be heard to be loud and clanging. Now, this is important. The second sound quality can sometimes be the only factor which can indicate the presence of a patent ductus arteriosus. Sometimes with a large shunt, you may not have enough with a large ductus and a high pulmonary pressure. You may not have enough shunt to cause a murmur, but the second heart sound, the clanging, loud and clanging sound, can give away the fact that there is a PDA. Sometimes you may mistake it for a pulmonary ejection click, but it's important to bear in mind and distinguish it from a pulmonary ejection click and appreciate the presence of a patent ductus arteriosus. Investigative modalities. Chest X-ray does not give a direct evidence of a PDA, but indirect evidence in the form of cardiomegaly. Like you said, it will be dilatation of the left atrium and left ventricle. So you have a smooth contour of the left side of the heart, silhouette, and you may have increased pulmonary vascularity depending on the shunt and cardiomegaly, like I said. ECG does not again contribute too much to a PDA diagnosis, except for the fact that you may have left-sided voltage predominance, which again is not too great a marker for diagnosing a PDA. Echocardiography is what gives a confirmative diagnosis of patent ductus arteriosus, and it can give you a lot of details about the quantity of the shunt, the hemodynamic effect, the pulmonary pressures, so on. And of course, angiography is not done routinely as an investigative modality for determining duct, except when it's associated with a complex congenital heart disease where the duct is perceived to be perfusing the systemic or pulmonary circulation, or when you are planning to do a transcatheter intervention on the ductus. So this is an X-ray. I want you to look at both these X-rays and tell me what the findings are. First, on the X-ray of the 4-year-old, and on the right, you see the X-ray of an adult, both with patent ductus arteriosus. So on the left, what are the findings? So on the left, the 4-year-old's X-ray shows a mild cardiomegaly with a rounded left ventricular contour. So pulmonary vascularity may be mildly increased, not too prominent. But what about the X-ray of the adult with the PDA? What do you think are the findings here? So you have the aortic knuckle, RV apex. What is this? That would be a dilated main pulmonary artery, and the left atrial bay is concave, indicating that there is no left atrial enlargement, and you have a smallish rounded left ventricle. You don't see much of RA dilatation, and you see prominent right and left pulmonary arteries. Anything else? And these vascular markings, you see, they stop 2/3 of the way across the lung. So there is bilateral, peripheral pruning of the pulmonary vasculature with a small heart, a dilated pulmonary artery, prominent proximal pulmonary arteries. So this is an adult with a large ductal shunt and severe pulmonary artery hypertension, most probably irreversible. Okay, so this is again two patients with patent ductus arteriosus. Tell me your findings on the X-ray of the 4-year-old child on the left of the screen. What is the findings there? What is the finding in this X-ray? Anything which stands out? Well, I got an answer which says device. Now, if you look at that carefully, this is a coil. Okay, so a coil closure of a duct has been done in this child, and that's predominantly that kind of indicates where the ductal position is on a AP view of a chest X-ray. So you have the pulmonary artery going like this from the right ventricle and dividing into left and right posteriorly, and that is where the descending aorta would be. The aorta would go like this and like this. So you would have the ductal shunt about there, and you have a coil which has been deployed. One turn in the left pulmonary artery and the other turn in the aortic side, and intervening coil comes across the body of the ductus. So this is how a chest X-ray of a child who's had a coil closure will look like. Important to know this because sometimes seeing this kind of an X-ray, the pediatrician may attribute it to a foreign body ingested or aspirated. Now moving on to the X-ray on the right of the screen, what are your findings? This is an adult female with a large patent ductus arteriosus, and you see what is one finding which stands out here. Aneurysm is one question which has been asked. Okay. It's a dilated pulmonary artery. Yeah. It's a dilated pulmonary artery. But is there anything else which is prominent, which something you should look for in an X-ray with in an adult who's had a long-standing shunt? So I'll put a pointer here. What is this? What is this shadow? The white shadow that you see. What do you see? What do you think that is? This is what I'm pointing to. This one. If you can see my screen, yeah. So what is that? That's a white shadow in the pulmonary artery, around about where the patent ductus would be. So what do you attribute that to? Fibrosis with calcification, correct? Yeah. So it is a calcified ductus. So sometimes, rarely, long-standing ductus with a bit of aneurysm sometimes can get calcified. And what is the implication of that in terms of management? So calcification does not imply a large shunt. It's just the morphology which has become calcified. The body of the duct, it could be a restrictive duct too, which needs closure. So what is the implication of a calcified ductus? How would you manage that? So basically the ductus is like an eggshell. Yeah. So it can crack if you handle it roughly. So how would you manage this kind of a patient who presents to you with a ductal shunt and a calcification of the ductus? Would you do a device closure? Yes or no? Intervention difficult, says one answer. Would you do a device closure, and if so, if not, why? Okay, no is the answer. That is correct. You cannot do a device closure in this patient, as manipulation can cause cracking of the ductus and rather fatal consequences. Would you send the patient for surgery? And if so, what kind of surgery would the patient do? Yes, is an answer. How? What kind of surgery would? What would you ask the surgeon to do, or what would the surgeon do in this case? How would he manage this kind of PDA? So I would give you the answer. This is the surgeon would not ligate this, as obviously that would cause damage. So one option would be to do an open heart, open the pulmonary artery, and put a patch from the pulmonary artery end and close on that side. That's the surgical technique to close, which was used to close such calcified PDAs in earlier years. But is there an intervention which is available to manage these calcified ductus? A transcatheter intervention, is there any way you can, I'll give you a clue, exclude the ductus through means of an intervention? The clue being exclusion of the ductal shunt. What intervention would that be? Embolization, again, you cannot go enter the ductus. It's very dangerous to either put a coil or device into the ductus. So the answer would be to put a covered stent. There are stents available with a, uh, a covering on the outside, and these covered stents commonly used for treating coarctations of aorta can be used to exclude the calcified ductus. So that's one way of management of calcified ductus by the transcatheter route. Like I said, ECG doesn't contribute much. There's upward concavity in ST segments in lead 2, 3, AVF, V5, V6 is a useful pointer to PDA, but don't know how useful that could be. If it's hypertensive PDA, then you can have a right axis deviation and RVH. Now, what's important is echocardiography, and it's important for all neonatologists and pediatricians, especially neonatologists, to be able to do at least a basic echocardiography to determine the quantity or extent of the ductal magnitude of the ductal shunt. This is what we call a parasternal short axis view, where the heart has been transected at the level of the aorta, a short axis. So you see the aorta as a round structure here. You have the pulmonary artery coming anteriorly down here and dividing into right pulmonary artery, left pulmonary artery, and this flow you see, this is the descending aorta down here, and this flow you see is the ductal shunt. Again, this is the same view in a different cardiac cycle, where you see the ductal shunt. Now the probe is here, so any flow towards the probe is shown as red, any flow away would be shown as blue. So that's common for echocardiographic views. The probe position is here, so any flow towards the probe would show as red, and this is a left to right shunt where the flow is from descending aorta into the pulmonary artery, and like I said, the ductal insertion is close to the left pulmonary artery. So this is a parasternal short axis view, a high parasternal short axis view, where or typically called the ductal view. And it's important for you to be able to, if you have an echo machine in the ICU, you should be continuously practice this view so that you can determine the views. This is a common echocardiography windows. You have 4 major windows for doing echocardiography, and the commonest is apical. You have the heart here, you put the probe at the apex with the marker to the left of the patient, and that would the ultrasound waves would transect the heart in such a way that you get 4 chambers of the heart, LA, RA, RV, and LV. And if you put it in at the parasternal region, you can get a short axis or long axis of the heart, depending on what you want to see. Subcostal view would be below the epigastric region, and looking at the heart mainly to look at the atrial septum, interatrial septum, the pulmonary veins, SVC, IVC, etc. And suprasternal notch view, where you could delineate the aortic arch and its branches, and also the ductus. So these are the 4 major views of echocardiography windows. If you have an echo machine in your unit, you should familiarize yourself with this so that you can look at least a decent 4-chamber view and a ductal view to determine the presence or absence of a ductus as one of the contributing factors to the baby's stay in the hospital. The parasternal short axis view is what is used predominantly to look at the ductus. This is the probe here with the marker to the left, and this is placed somewhere across the pulmonary artery, and you can see you can sweep either high or mid or lower down to get whatever short axis views you get. And this is the same cartoon which depicts a parasternal short axis view. So here you see this is what we would look at, a parasternal short axis view, the aorta with all 3 leaflets. This is the left coronary cusp, the right and the non-coronary. You have the tricuspid valve here, the pulmonary valve, and the pulmonary artery. And if you go higher up, then you would open up the branches, the right pulmonary artery and the left pulmonary artery, and the duct. So this is a high parasternal short axis view. This is how it would look. This is an autopsy specimen where you see the right pulmonary artery and the left pulmonary artery, and descending aorta would be here, and you see a ductal flow coming in. The high parasternal or ductal view. So here is how the duct inserts into the pulmonary artery confluence. As you can see, it's close to the left pulmonary artery origin, and you put the probe fairly higher up, and by placing the transducer high in the precordium, usually in the first intercostal space, and obtaining a section of the MPA, LPA, and the descending aorta in the parasagittal plane. This is an echo video which would not play in this, but this is a Doppler. Again, Doppler is a measure of the velocity of the blood flow across the shunt. As you can see, this is a red flow, which indicates that the flow is from the descending aorta into the pulmonary artery, and the velocity here is about 2.2 meters per second, which again, using Bernoulli's equation, you can translate that into pressure gradient, and 2 meters per second would roughly translate to about 16 millimeters of mercury. So the pressure gradient is calculated using Bernoulli's equation, which is P equals 4 V square, square of the velocity. So here it's 2 meters per second. So 2 square is 4, and multiply by 4, you get a pressure gradient of 16 millimeters of mercury. So the pressure gradient tells you that the difference in pressure between the aorta, descending aorta, and the pulmonary artery is, in this case, only 16 millimeters of mercury, which tells you that the pulmonary pressures are still high. If it's a neonate, the pulmonary pressures have not fallen down. If it's an older patient, then there is severe pulmonary hypertension as a consequence of the ductal shunt, and the shunt is low. The higher the velocity, the lower the pulmonary artery pressure. So as you know, the pressure in the descending aorta would be the systolic blood pressure, which you would measure by doing with the sphygmomanometer, and the pulmonary artery pressure is usually commonly 1/5 of the systolic artery pressure, and it should be in a restrictive shunt. You would have a gradient of 60 to 80 millimeters of mercury systolic, and that would indicate a low pulmonary artery pressure. So again, this would not play. I don't think it's going to play. So this is a high ductal view, where you see shunt coming from the descending aorta into the pulmonary artery, and you can see a lot of turbulence in the flow, which tells you that the neck of the PDA is quite restrictive, and you would have a higher velocity flow with a high gradient. So that would again indicate that it's a restrictive shunt with low pulmonary artery pressures. So here is a flow which is non-turbulent, wide. So this again, just the color flow tells you that the flow, the pulmonary artery pressures are quite high, and the gradient is likely to be low. LA to iota ratio is again an important factor, which can give an estimate of the magnitude of the ductal shunt. This is the M mode, which has been dropped across the aorta and the pulmonary artery in a long axis view of echocardiography of the heart. So you have the aorta, and this is the left atrium, and as you can see, this is fairly dilated, and the LA by iota ratio here is 2.2. Anything more than 1.6 is considered significant. So these are all some examples of Doppler velocities across the ductus. As you can see here, this is a bidirectional shunt. Systolic, you have left to right shunt, and diastolic, you have a right to left shunt, which indicates bidirectional shunting, high PA pressure. This indicates a predominantly left to right shunt with systolic accentuation, diastolic pressure coming down slightly, not to the baseline, like here, which would indicate that there is moderate shunt even during the diastolic phase. So these are all some ways which look at the quantification of shunt. You can quantify a left to right shunt using LVOT versus RVOT flow, and SVC flow versus LVOT flow, LPA diastolic flow, and the flow is calculated using this formula, which is heart rate into velocity terminal integral into area. So PDA in premature babies, we have seen already that the incidence is higher and the symptoms are more commonly because of steal of the cerebral, splanchnic, coronary, and renal flow. So you have higher incidence of renal dysfunction, you have intraventricular hemorrhage, periventricular leukomalacia, and splanchnic like necrotizing enterocolitis. All these are associated with a large significant ductal shunt. And how do you signify a PDA in neonates? You have a diameter. If it's more than 3, it's large by echo. If the ductal velocity is less than 1.5 meters per second, then it signifies a large shunt with high PA pressures. PA flow velocity again can be used in the LPA to signify a shunt. LA aortic ratio, like I said, more than 1.6. And also retrograde aortic flow more than 50%. When you have a large duct, majority of the flow goes into the pulmonary artery in systole and diastole. So you have a lot of steal from the systemic circulation, with the result that when you Doppler the descending aorta, you would see a significant proportion of blood coming in the reverse direction during diastole. So that is an indication. If that's more than 50%, then that's an indication of a significant ductal steal. So these are just some examples of aortogram. This is a small ductus, as you can see, a type A ductus. This is a pigtail catheter in the descending aortogram. This is a lateral aortogram. You're looking at the baby from the side. This is the front, the sternum here, and the spine here. Just imagine that you're looking at the baby from the shoulder, the side. And this is an angiogram which is done in the aorta. You see a duct which is small at the pulmonary artery end. In a normal aortogram, without a duct, you would not see the main pulmonary artery opacify. And this is a large ductus in a older patient, hypertensive ductus. You see again a type A, but the neck of the PDA is quite large. And when it's so large, then we do a balloon occlusion to make sure that the PA pressures do come down with occlusion of the ductus, and it's not an irreversible pulmonary hypertension, which can be detrimental if you close the ductus in those kind of situations. So unless the pulmonary artery pressures are reversible, you would not go and device close a duct that big. So these are all some angiographic views of different morphologies. So you have complex ductus, and like I said, it's important to know these morphologies so that you can plan ductal closure, transcatheter ductal closure accordingly. So if you look at the management of PDA in preterm babies, I think we are running out of time. We'll just quickly go through that. So what makes it important to manage the PDA is its association with intraventricular hemorrhage, bronchopulmonary dysplasia, and necrotizing enterocolitis. But again, what makes it important during the management is to consider the adverse effects of the pharmacotherapy or the intervention that we need to do. So management, mainly fluid therapy. There has been a lot of discussion about fluid therapy, whether fluid restriction, severe fluid restriction helps in curtailing the ductal shunt. A lot of studies which advocate that, but of late the consensus is that the fluid overload more than 170 ml per kg per day on day 3 of the neonate or preterm baby's life is what correlates with a large persistence of a PDA thereafter. So the consensus is that you do not cut down on the fluid excessively but you do not give more than 170 ml per kg per day for the first 3 days of life. You do not exceed 170 ml per kg per day. Pharmacotherapy, you must be all well aware, indomethacin has been commonly used. Now, indomethacin also has the most complications associated with its use. If mainly the if contraindications like if you have GI bleed, if you have renal dysfunction, if you have a cerebral bleed, then you cannot use indomethacin. If indomethacin is preferably used as a IV infusion, and commonly the dose is if the baby is less than 48 hours old, you give 0.2 milligram per kg as a single dose, followed by 0.1 and 0.1 at 12-hour intervals, provided the urine output is more than 1 ml per kg per day. If it is less, then you adjust the dose accordingly, or even withhold it if the urine output is less than 0.6 ml per kg per day. And if it's a 2 to 7 day old baby, then your dose is 0.2 milligram per kg at 12-hour intervals, 3 doses for one course. And if it is more than 7 days, you can give 0.2 milligram per kg the first dose, and 0.25 and 0.25 subsequent 2 doses at 12-hour intervals, provided the urine output is monitored and it's adequate, like I said. If the urine output is not adequate, then you either control the dose or withhold the dose between the second and third dose. BNP has been used as a monitoring marker for treatment with indomethacin. Ibuprofen is considered much safer given orally, less side effects. The only side effect of ibuprofen being that it can displace albumin from the bilirubin binding site. So there's a chance of kernicterus with ibuprofen therapy. So that has to be watched. Otherwise, the side effects like renal dysfunction and necrotizing enterocolitis, GI bleed are less with ibuprofen. Equally effective as indomethacin. Of late, paracetamol is being advised for use, about 60 milligram per kg per day in 4 divided doses. And this has been found to be much safer, but we have to wait and see whether this can be continued. Larger studies are required for advocating use of paracetamol. Surgical ligation, it's almost redundant now, because even preterm babies are amenable now to for closure with devices. There are devices available which can be used, and transcatheter intervention has of late come into a larger use. So surgical ligation is very limited. And these are the duct occluders that you use for closing these PDAs. You have, this is a coil with polyester threads which enhance clotting. This is a duct occluder made of nickel and titanium alloy. Here is the cable which it's attached to, and this comes on the aortic end, and this comes across the neck of the ductus, and this one stays in the pulmonary artery end. So it's like a plug which stays there. These are again nickel and titanium devices which are made of smaller and finer wires for closing large duct in smaller babies, preterm babies. And these are called Amplatzer duct occluders, additional size for preterm babies. So here is an example of a ductal device closure. Again, you see a fairly large ductal shunt here, which has been closed using an Amplatzer duct occluder. So you have one retention disc in the pulmonary artery, the middle disc in the body of the ductus, and one retention disc in the descending aorta. So this is a retrograde device closure of duct in a small baby. And older children with very small complex PDA, small shunt. This coil closure has been done from the retrograde side. So this takes care of a small shunt, mainly to prevent the risk of endarteritis. Here the shunt is not significant, but mainly to prevent the risk of endarteritis. And in older children, you do what is called a device closure using the plug that I showed you. This is how the device is advanced through a delivery sheath. Here the sheath is from the IVC, RA, RB, pulmonary artery across the duct into the descending aorta, and the device is being advanced here. And here the device has been deployed across the ductus, stability is checked, and once stability is checked and released, you see that the duct is completely closed. So when we talk about ductus arteriosus, we have to talk about duct dependent circulation. We can't always be closing the ductus. We have to, at certain situations, keep the ductus patent. And this is a child with pulmonary atresia where the aortogram shows a duct dependent pulmonary circulation. Here is an injection into the ductus which shows pulmonary atresia. This is called a Siegel view. And here it's important to stent the ductus and keep it patent. So instead of doing this is a surgical alternative to a BT shunt. So you put a stent in the ductus, and the end result is that you have a widely patent ductus which has been stented to provide initial palliation, and subsequent palliations will be carried out later. And this is an example of a covered stent for patent ductus arteriosus, especially when it's associated with coarctation of aorta. So this is the ascending aorta here. You have a tight coarct, a large duct, opacifying MPA, and the descending aorta is normal. So both of these lesions are addressed in one go with the deployment of a covered stent, which would relieve the coarctation narrowing as well as close off the ductal shunt. You see the ductal shunt is completely closed. So this is covered stent for PDA. This is one situation where the covered stent is used. The other one being exclusion of the ductal shunt in a duct which is calcified. So I'm just going to run through, this is the last few slides. Just going to run through some differential diagnosis of or unusual diagnosis of ductus. This is a child who had bilateral ducti. Okay, so here is a condition where you have a right duct and a left duct in a non-confluent pulmonary arteries. And the embryological basis for that is persistence of the ducti on either side, both right and left. And this was a case of pulmonary atresia with non-confluent pulmonary arteries. And what do you see here? So this is an aortogram which shows a structure which is arising proximal to the left subclavian artery and perfusing a PA confluence, which can mimic a patent ductus arteriosus. So that is basically persistence of the fifth aortic arch. Okay, persistence of the fifth aortic arch can mimic a PDA, and the other conditions that can mimic a PDA here is a coronary cameral fistula. So these are all conditions which would produce a continuous murmur, but in unusual locations. So it's important to identify the location, and based on that, you can diagnose. This is a pulmonary AV malformations, as you can see. So the continuous murmur is over the right chest wall here in this case. Here it would be lower down along the aortic area. in the coronary cameral fistula. This is an example of a aortopulmonary window, a residual aortopulmonary window, and which then was closed with the device. This is a ruptured sinus of Valsalva. Again, can have a sudden onset with symptoms of continuous shunt and large left to right shunt. So that ends my talk on patent ductus arteriosus diagnosis and management. And I hope you found it useful, and all the very best to you. Thank you.
Thank you, doctor.
Thank you. I've sent you the MCQs, Amrita, so you can.
Yeah, I have seen. I have seen that.
Thanks a lot.
Yeah.
Sir, thank you.
Thanks. I'm just trying to leave the meeting.
Yeah. Bye, sir.
So bye then.
WNC Naikar have a question. Hello, sir. Hello, sir. So we have a question. WNC Naikar